Good evening, everybody. We would like to welcome you to the August 3rd Thursday. We've got an excellent presentation that I'm really looking forward to seeing of clinical staging of hypothermia by Dr. Martin Musi and Dr. Allison Sheets. And with that, I'd like to introduce Doug McCall, President of the Mountain Rescue Association. Say a few words.
Thank you, Michael, and thank you, Martin and Allison, for presenting tonight. Wanted to welcome all the MRA teams who are joining tonight, MRA members, and also we've opened up the third Thursday to a broader audience. And so if you're joining from another search and rescue team or a non-MRA team, we want to welcome you to this third Thursday. Our third Thursday programming is set up by our MRA Education Committee, and it is designed to bring timely training and online content and share that with teams across the country and around the world as people are tuning in. So if you want to catch the latest third Thursday, if you can't make it on the third Thursday, you can catch the MRA YouTube channel where we record these presentations, and you can catch them and watch them if you miss something and you want to go back, or if you want to just catch it in your own time. So thank you everyone for joining. Thank you again, Michael, for hosting, Eva from the Education Committee, and Martin and Allison. I will turn it back over to you, Michael. Thank you.
Thank you, Doug. We also just want to give a plug for our September third Thursday that'll be integrating civilian aviation and hoist programs. It's an outstanding cadre of instructors, and I know it'll be an outstanding presentation. So look for that coming up in September. And next, I just want to thank the following people: Kate Larson, who did the marketing for us, and Gary Ferris, who's our MRA webmaster, and Ava, who's hosting our Zoom tonight and making sure that all goes well. And as Doug said, this will be recorded and available at a future date for you to miss or watch if you weren't able to make tonight or know some people that were interested. And so with that, I'm going to unshare my screen and we'll get started with tonight's presentation.
Hello, my name is Martin Musi. Thanks to the MRA for the invitation for giving this presentation. I'm a member of Rocky Mountain Rescue here in Boulder, Colorado. I'm also an emergency physician at University of Colorado, originally from Argentina. Hear the thick accent from, and thanks everybody for being here.
Hi, my name is Allison Sheets. I'm also with Rocky Mountain Rescue Group and I'm an emergency physician here in Boulder, Colorado. A lot of you may know me as I'm the MRA Vice President, and I'm also the MRA ICAR Medical Commission Delegate. And with that, we'll get started. Why are we talking about hypothermia in the middle of summer, Martin?
You know, hypothermia is very relevant to every aspect of mountain rescue. It can happen in every type of climate, even tropical, subtropical regions. So it is a relevant topic even in the summer. So today we're going to talk about hypothermia, especially about accidental hypothermia. We're going to define those terms. I'm going to talk a little bit about what's the pathophysiology, what happens to the human body when it's exposed to cold.
It's not good.
Not good. I'm going to talk a little bit about the clinical assessment. What do we see in signs and symptoms on patients suffering from hypothermia? I'm going to go over what's the staging. Staging means classification. And basically, what's the classification of severity of patients with hypothermia? And with Allison and other co-authors, we published recently a revision of the Swiss staging system, and we're going to go over what are those changes. Good. And lastly, we're going to touch a bit on, the treatment of patients with hypothermia in the setting of mountain rescue. Great. But what's hypothermia? Let's try to define this for a bit.
Well, the definition of hypothermia is pretty simple. It's really the body gets too cold and can no longer generate enough heat for normal body systems. And it's generally defined as equal to or less than 35 degrees centigrade.
Yes, no Fahrenheit, right?
No Fahrenheit.
No barbaric units here.
None of that. And
That.
primary hypothermia is you just get cold, whereas secondary hypothermia is where you get cold, but also there's maybe some other illnesses you have. Maybe you're intoxicated, maybe you're on some medications or some other comorbidities. Elderly, for instance, can get cold in a way that's not just related to a cold environment, but also because their body, for other reasons, can't maintain core temperature.
Yeah, so, hypothermia is the disease of the exposed, right? Could be your alpine climber, your lost hiker, but also
Or you get wet.
Yeah, like in wet and cold environments, especially when there is wind and convection, ways of losing body heat, but also is the, disease of our most vulnerable populations in the urban cities, right? Homeless, which usually hypothermia in the setting of the mountains or the cities is usually never alone, right? There's many friends of hypothermia that can hurt you. Drugs, alcohol, what else?
Well, if you're asphyxia from drowning or from snow burial, or if you've got medications, certain folks with psychiatric illnesses can just not get themselves out of a cold environment and be susceptible in that way. Lots of reasons to be susceptible to the cold.
Cool. But what do we see in, patients with hypothermia? What are the clinical presentations, the signs and symptoms of patients suffering from hypothermia?
So I learned when I first did first aid training in EMT, the UMBLs. I don't know how many of you have heard that, but the UMBLs stand for stumbling, mumbling, fumbling, and bumbling. So when people get really cold, and a lot of you have probably experienced this, you get a little bit hand-eye coordination, dexterity goes down. You maybe have a little bit of word finding difficulties. You can be a little unsteady on your feet. And those are early signs of a cold injury, and you really need to pay attention to those subtle changes when they're happening.
So hypothermia is a spectrum, right? That starts from minimal symptoms and can progress to, pretty severe affectations of vital signs and, unconsciousness and going into, hypothermic cardiac arrest, right? So let's dive into what happens that, the most important symptom or the most important system when we lose core temperature. At the central nervous system, the brain, initially, there might be a little bit of stimulation with, a small decrease on the core temperature, and patients can have even agitation and can be like acting hyper a little bit. But
at first,
progressively, there is, clumsiness, subtle behavior changes, and then progressively decrease on the level of consciousness. And we use decreased level of consciousness as one of the most important elements or clinical elements for the classification of hypothermia. We're going to dive in a bit more on our revised risk system. You need to remember that patients that have severe hypothermia might look dead. The typical signs that we look for signs of life, like unreactive pupils or corneal reflexes, might be absent. At the cardiovascular system, initially might be a little bit of a sympathetic stimulation. There might be a little bit of elevation of the heart rate, but progressively, with decrease of core temperature, there is a decrease of all the functions of the cardiovascular system, especially your heart. They can be abnormal rhythms. And what happens is usually your heart goes and starts beating very slow, and you start losing your tone at the level of your, peripheral vasculature, resulting in hypotension. So low blood pressure and low heart rate.
And this is why you always want to check somebody's pulse for at least a full minute. If you've got a cold patient and you're doing vital signs, you need to use the carotid pulse and check for a full 60 seconds or 1 minute minimum.
Yeah, if you take your pulse now and take it for 60 seconds, it's a long time. So take a very long time to detect if there is any presence or absence of pulses. Because if you start CPR on that patient, you might lose them. You might put them in a non-perfusion rhythm by pressing on their chest. So, take your time. At a respiratory level, your patient might be breathing very shallow and very with a low respiratory rate, something that we call bradypnea. They might not be even breathing at all, right?
Again, you have to take your time and really assess if there's any kind of respiratory effort. Make note of that.
So what's the myth in hypothermia? Why is it so important to detect those patients that have very severe hypothermia and they might lost their vital signs? What is that difference from, let's say, a cardiac arrest that happens from any other causes, heart attacks, heart disease? It is because the prognosis or the potential survival from a hypothermic cardiac arrest is much higher than patients with cardiac arrest from any other causes. Let's take a look at some numbers here. So this is the survivability of non-hypothermic cardiac arrest in an ambulance service. What do you think about that number, Alison?
Well, I don't think this is actually ambulance service. This is a hospital-based study. So 8.8% survivability from non-hypothermic cardiac arrest is pretty high. And that would be more likely to be witness cardiac arrest or cardiac arrest in a more urban environment. This has nothing to do with wilderness medicine or what we do in search and rescue environments. The other thing to keep in mind is that ECMO, that stands for extracorporeal membrane oxygenation, that's a very advanced procedure. And so this is a study that looked at people that were brought to a hospital with the hope that they might be salvageable. These are people that were in cardiac arrest for whatever reason, were placed on ECMO and who survived, and that's where these numbers come from. And so there's a certain selection bias in this study because all the patients that came to the hospital were thought to be viable, at least initially.
I think that the bottom line is that patients with hypothermic cardiac arrest, even after prolonged CPR, prolonged evacuation, prolonged times of, hours, they might walk out of the hospital with normal neurologic recovery if they are treated correctly and they are rewarmed. Let's think about the brain being on a type of metabolic ice box where they are completely preserved. This is depending if there was asphyxia before hypothermia or there was no asphyxia after the setting of hypothermia. We're gonna get there a little bit more in deep.
Yeah, asphyxia is bad. We'll
Yep.
just leave it at that for now.
Yep. So staging of hypothermia, staging meaning classification, is important for many, many reasons. One is informing our treatment is this patient very sick? What is the level of care that this patient needs? It's going to tell us what is the prognosis and what's the estimation of the risk of cardiac arrest. And it's going to, more importantly, influence our decisions on triage, evacuation, and what's the destination hospital, right?
Yep.
So what Alison was talking about ECMO happens in very specific hospital with a lot of resources that might not be present in smaller facilities. What's the best way of classify patients with hypothermia? So we know that the best way to classify patients with hypothermia is actually knowing what's their core temperature, because that correlates with, very likely with the risk of cardiac arrest. What's the problem with this, Alison?
Well, core temperatures are true core temperatures, and really the most reliable measurement of core temperature is an esophageal probe, which is placed by an advanced provider in an intubated patient who's no longer breathing on their own, and it goes all the way down the esophagus and lands right behind the heart, and that tells you what the real core temperature is. Now, most of us can't do that in the field for a variety of reasons. And all those other ways we have of taking temperature in the ear, the forehead, the mouth, they're terrible in these cold environments. And so we found that core temperature is not very useful to either estimate or to actually obtain in a true mountain rescue environment.
So in 2005, there was a position paper published by the International Commission of Alpine Rescue that was called the Swiss Staging System for Hypothermia, and basically classified patients from HT1 through HT5 based only on their clinical findings to try to estimate what were their core temperature. They classified basically in the presence or absence of shivering, in their level of consciousness, and in their presence or absence of vital signs. HT5, death due to irreversible hypothermia, you see a 13.7 with a question mark over there, was later removed from the classification. That's the, at that point was the lowest temperature that a human being has been resuscitated from accidental hypothermia. The case of the radiologist that went down, under a frozen river and, got extricated and resuscitated with ECMO and basically survived with normal neurologic recovery. Nowadays, we don't know exactly what's the lowest temperature that a human being can be resuscitated. Actually, for accidental hypothermia, 11.8 is the lowest temperature that we know of a pediatric patient that had pretty profound hypothermia.
So what's the problem with our Swiss staging, the original one, is that these temperatures that you see on the right-hand side related to HT1, 2, 3, 4, and 5, those temperatures really don't have any basis in actual field data or even in reality. And so several studies have been done looking at patients that are, again, transported to a hospital that are hypothermic, and then actually looking at the clinical findings. So clinical findings being what you can see and measure in a field situation or in real life, and compare those to what their actual core temperatures ended up being when they were measured by esophageal probes or other ways. And we found that really there was only about a 60% correlation rate, which is, just a little bit better than 50-50. So the bottom line is that those temperatures that were listed for those stages of clinical findings were all over the place and really don't relate to the stages at all. So that's what prompted us to revise the Swiss staging system. And we'll get into how we did that in the next few slides.
Great. So we published this article in Resuscitation in May, I think.
Kind of a big deal.
Trying to, go back and see what are the most important clinical findings to determine the level of hypothermia. And I think that it's important to go over the changes. We think that the most important change that we made, that we changed the focus of the classification. And this was from estimation of core temperature
which wasn't very good
by the original Swiss system to estimate what's the risk of hypothermic cardiac arrest.
Which makes a difference in how you treat a patient in a clinical setting or in a rescue environment.
The second change that we did was change the wording and scale when we were assessing the level of consciousness. In the original Swiss system, there were words like impaired consciousness or abnormal consciousness, and that's very variable. And if we want to have a classification that is reproducible by many, many people using it in the field, we thought that was useful to use a scale that was known by the majority of the providers. So we changed the level of consciousness assessment by using the AVPU scale. So if the patient is awake and alert, is the patient responding only to verbal stimulation? Is the patient responding to only painful stimulation, or is the patient unresponsive completely? We think that this has many advantages, especially it is simple for field use, it is reproducible, and correlates with other mental status scales like the Glasgow Coma scale that I still need to use my fingers to count.
I can never remember it. 3 is a rock.
It has some disadvantage as well, right? Consciousness might be impaired for multiple reasons. We talked that hypothermia is usually in conjunction with other conditions, like for example, toxic, like toxic exposure, alcohol intoxications, use of drugs,
trauma.
So, like if a patient has hypothermia and has one of these, like coexisting conditions, that might be affecting the level of consciousness by itself. So we think that the use of the revised Swiss system should be used on primary and pure accidental hypothermia.
Cold only, no trauma, no intoxication, no comorbidities, or any other reason for the patient to have altered mentation. That's an important, very important part of the revised system.
Cool. We discussed a lot on shivering, right?
Too much.
There was, there was advocates for leaving shivering into the classification. There was, but in the end, we realized that shivering might be a very, variable sign. So the presence or absence of shivering took it out, no longer used as a stage defining sign, because correlates poorly with core temperature. And actually also it is very variable in presentation. Some patients might have shivering even when their, temperature, core temperature is very low and their risk of cardiac arrest is high. When present usually means that the core temperature is probably above 30 degrees Celsius, a temperature at which hypothermic cardiac arrest is unlikely to occur. So maybe on the original Swiss staging system of 1 or 2, but their risk of cardiac arrest is lower. But if you have a patient that is shivering but has a decreased level of consciousness, just go for the worst.
Be worried.
Classify that patient and don't be reassured by the presence of shivering, because that patient might be sicker than you think.
All right, so this is the meat of what we did, and this is a picture of our staging system, and take a few moments to read the A, B, and C, those notes, and Martina's going to describe it to you. We'll refer to the colors. As you can see, there's a gradation between the colors. There's no hard stops between the colors until you get into stage 4. Yeah,
so we classify patients based on their level of consciousness and based on the presence or absence of vital signs. And we classified it in 4 stages, stage 1 through 4. As you see, a patient that is completely alert will have a low risk of cardiac arrest. That doesn't mean that they don't have any risk at all. And that's why we graph that with a color grading, because if those patients, might be a bit confused or a little bit, like weird, they might have, a lower core temperature, and that patient might be at risk of cardiac arrest still. And we don't say that that patient is not at all at any risk of cardiac arrest due to hypothermia.
And stage 1 obviously is going to have vital signs, as is stage 2. We don't put it in there because it should be understood when somebody's awake and talking or able to respond verbally, they'll have vital signs.
Yeah. So moderate stage or stage 2 will be patients responding to verbal stimuli, or, and if the patient is, has a abnormal level of mental status, they are weird, again, I will put them into the moderate risk of cardiac arrest. And then you have patients that are only responding to painful stimuli, or patients that are conscious. They have vital signs that are present. Those vital signs might be abnormal. You might have, very low heart rate and low blood pressure. So those patients are at a very high risk of cardiac arrest because they are unstable. Okay. Of course, if patients don't have any vital signs at all, right? No detectable pulse, no detectable ventilations taken for at least 1 minute. Okay. That's when you are in stage 4 and you are in hypothermic cardiac arrest.
Not good.
Not good. Again, we don't think that the staging of patients, we don't think that every patient is the same, and patients with comorbidities, all right, heart attacks, diabetes,
a history of heart attacks, or a history of diabetes.
Those patients might have even higher risk than other patients without that characteristic, that prior characteristics of cardiac arrest due to hypothermia. So, like we acknowledge that the risk of cardiac arrest is also very variable among individuals.
It is. And if you look at the note C, consider other causes of mixed picture. So if you have someone who has, let's say, normal vital signs, but they're acting very strange, or they're unconscious or only responsive to painful stimuli, you have to consider that there may be something else going on. So use this liberally. Always be more conservative in your decision making. Assume the worst, and treat for the worst. But if things aren't making sense to you, definitely consider other causes for altered mentation besides hypothermia. Because remember, this is for people with primary hypothermia only, nothing else like trauma, intoxication, or medical illness.
So our work was intended to provide, a very useful tool, like the original Swiss station, or the concept of try to grade our patients based on our clinical assessment, back to, like trying to, in a way, do it a little bit more simplistic, okay? And try to, pan the big picture of our patient, more than being very focused on what is actually their core temperature. All those numbers that we will never remember, what was the cutoff, was 24, was 28, that, like it's important from an academic perspective, but from a field perspective, it's much more important to know, where is your patient going, how sick it is, what level of resources do we need to provide to them.
Yeah, this is really aimed for mountain rescue personnel. And I got to hand it to Martin, because he did some of these changes that were really profound to make it useful for clinicians that are not necessarily physicians or advanced care providers. So thanks everybody for the hard work on this. So the last bit of our talk is going to be on the treatment of the hypothermic patient. I'm going to talk about that. And again, this is going to be in the context of a mountain rescue. So I think the very first thing you need to think about to treat a hypothermic patient is to prevent further heat loss. And I see this forgotten often. And the prime example, I'm in Boulder. There's lots of active people all times of the year, and you can get people out in November. It may be a sunny day and they're out running in shorts, and they fall down, hurt themselves, get an ankle, whatever, and you come up to them and they're barely dressed, and it's not necessarily cold outside, but they will lose heat very quickly. And so you really have to primarily, first and foremost, separate somebody from cold environments, put a pad underneath them, get them out of the wind, do whatever you can to prevent further heat loss, because people can cool down extremely quickly. And it's hard to warm people up, almost impossible to truly warm people up in the field. The gentle handling has to do with the sort of the irritable heart. When we talked about the cardiovascular effects, as the heart cools, there's some, fancy electrochemical changes that occur in the electrical activity within the heart. And as it gets closer to that high risk and gets closer to those temperatures where cardiac arrest occurs, rough handling, jostling, even doing procedures can push somebody over the edge from what was a bradycardia into an unstable cardiac rhythm or asystole. So treat these people carefully at all times when you're digging them out of the snow or packaging them up.
Remember that those patients got to, being hypothermic slowly over time, right? So you don't need to, like be on trauma mode, right? And, take your time. Of course, you want to be expeditious, but you don't need to rush things.
No. Remove wet clothing if able, and probably the biggest cause of hypothermia in most search and rescue environments is people getting wet in not necessarily bitter cold conditions, but just sort of chilly conditions, and then getting wet and really not dealing with that in a timely manner. If you can remove clothing, if you can get people out of exposed terrain, if you can prevent further heat loss and get that wet clothing off, and then put dry clothing next to their skin, do so. If you're not able to do that, and again, if they're in the snow and it's really windy, you take their wet clothes off, you're gonna really put them into trouble. Put some vapor barrier around them, something that's truly water and wind resistant, and then hopefully they can warm up those wet clothes. but try to dry people off if you possibly can.
Plastic bags, plastic sheets.
Bags, yeah, the space blankets that work for that, anything, even Gore-Tex, anything that's really wind and water resistant. And then as you package a patient, we'll show some pictures of the sort of classic burrito wrap. You want to package them so they're warm and snug, and that, you know, further wind or rain or snow won't get into them. But you also want to be able to access, if they've got an IV, if they've got a monitor, you want to be able to access their face if there's any need to do airways. But you also want to just be able to access them to reassess. You know, you need to see the patient's face. You need to talk to them if they're verbal. You need to touch their skin to get an accurate reassessment. So maintain access for reevaluation as best you can. And again, there's going to be circumstances if you're in a vertical litter evac, there's going to be times where you won't be able to reevaluate, but certainly on a long trail carry or something, you're going to probably take several moments to reevaluate as you go along.
Yeah, remember that, you know, when we do medicine, we really like to have, you know, contact with the skin, of course, like preventing further heat loss. But things that get missed by, you know, field teams get missed by the ambulance crew. What is missed by the ambulance crew get missed by the hospital doctor. So, you know, like if you never, but you know, like things that are communicated and found, you know, and communicated in the you know, hand off, it gets, you know, observed at least, and make sure that there's no other injuries. But make sure that you're assessing your patients, head to toe exams, you know, hands on the skin of the patient, and make sure that at least you visualize and examine different body parts. Don't be afraid of touching human beings.
Yeah, as long as you don't expose them to further heat loss. And then again, I just want to reiterate that we really don't do any active rewarming in the field. The best you can do is to prevent further heat loss and try some external warming, heat blankets, hot packs. Don't put any hot packs next to the skin. Don't put hot water bottles next to the skin because you can burn people. And if they're really sick, they won't be able to remove that heat from their body. And then last on the treatment is this consideration of intermittent CPR. And there it's got with EMS agency pre-plan. So intermittent CPR has come up recently in the International Commission of Alpine Rescue Environment and in mountain rescue in general, mostly based on a couple case reports where people that were severely hypothermic who had cardiac arrest, witnessed cardiac arrest in a field environment, ended up getting CPR intermittently. And the main case that I know about was in Poland. It was a 7-hour evac, and they had an automatic CPR machine that failed in the cold and wet environment. And so what they did is they just did the best they could as they were litter evacuating a patient. They did intermittent CPR. And 7 hours later, you know, patient gets to the hospital, and that patient ended up having pretty good neurologic outcome, was, you know, walked out of the hospital basically, even after essentially being dead for 7 hours. So there are some guidelines. The ICAR organization has some guidelines of intermittent CPR, you know, 5 minutes on, 5 minutes off, although none of that's based on actual studies. It's all kind of assumptions made. But there are times if somebody is cold and you think that they've gone into cardiac arrest from primary hypothermia, and there's no obstruction of the airway or other reason that they would be dead, there's no obvious trauma, and you think that they're viable, you can, you know, again, do the best you can, do CPR as best you can, and take them to the trailhead, with the plan being that EMS will then transport them to an appropriate facility. Now, the only problem with that is if you haven't worked this out ahead of time with your EMS agencies, you may find that an ambulance won't transport the patient doing CPR, or the helicopter may not be willing to transport a patient who's undergoing CPR. So, you know, if you're going to do this, you really need to pre-plan this with all your EMS agencies so that it's a seamless transition from the field to an ECMO center.
Yeah, and you know, going back to, you know, nobody's dead until warm and dead is, yeah, that mantra is still present because of, you know, these long evacuations with normal neurologic recovery. But at the same time, you need to consider you're not going to do CPR in someone that has a petrified, you know, chest. You're not going to do CPR
Frozen chest.
if there is frozen chest. If there, Alison is translating for me. Thank you. You're not going to do CPR in someone that has injuries that are not compatible with life. You're not going to do CPR if there is a increased risk for the team to do this, right? But if those are considerable options, and you want to move that patient to the trailhead in an evacuation, note that even suboptimal CPR, right? If you're doing CPR, it's better to do it without pause, hard and fast, and without interruption, right? But note that in the setting of primary accidental hypothermia, intermittent CPR might be still a viable option.
It might be. Talk to your medical directors about this, when to initiate resuscitation and also when not to initiate resuscitation. These are things that you really need to think about before you have to make decisions in the field. Otherwise, it's extremely difficult even when you're prepared. These are always, traumatic to the rescuers and to the people on scene. These are always fraught with emotion and intensity. So the more you pre-plan these things, the more you talk about the options and the protocols on how to initiate CPR or when not to, the better off you'll perform when you come upon these situations.
Yeah, this is not to put on the rescuers the incredible burden of like you're getting someone out and you decided not to do CPR. Like we do, we operate in a risky environment, and our safety is paramount. So it is a very important thing that shouldn't hunt you down if you didn't perform CPR in someone that you thought that might had a chance because of your safety.
All right, this shows the classic Burrito Wrap. It's published in multiple places, and the details of it are not so important. It's just that you've got the kind of the layers taken care of. That first layer, the light gray one, is going to be your vapor barrier liner, and they say plastic or foil, just something really impervious to water and wind, and that goes right next to the body. It shows heat packs there, although heat packs should be above clothing and never directly on the skin. And the way they show folding it allows you to sort of access that patient even when they're well wrapped up. And then you can see through 2, 3, and 4, just one technique with a big tarp on how to do that nice burrito wrap, and that will keep people really dry. And you can get some, external rewarming going in a longer evac, especially.
Great.
And then finally, I'm going to touch on what does a hospital want to know. I think this is applicable not just to hypothermic patients. Clearly, there's a lot of information that search and rescue gets that the people in that pre-hospital environment, even before the ambulance, us basically mountain rescuers, we get some of the information that no one else has access to. And so it's important to take that information, keep that information, and make sure it gets passed along as the patient gets passed along. And so a basic story, was it a fall into an icy cold stream with 20 or 30 minutes to get them out of it? Was it a slow backpacking trip where they just got colder, and finally, couldn't do anything? Was it fast? Was it slow? Was there trauma involved? What was the patient's baseline? Do they have any medical history that you know of that you got from bystanders on scene? So just get the basic story. It's kind of like the chief complaint or the subjective part of a SOAP note. What happened? Because oftentimes the mountain search and rescuers are the only ones that know that part of the story. So when we're talking about hypothermia, especially severe hypothermia or someone who might be in cardiac arrest, was there presence of vital signs in the field? Yes or no? Was the cardiac arrest witnessed, and if so, at what time? These are super important for prognosis and how hard the hospital is going to go on trying to resuscitate a really sick patient. Time of cardiac arrest if known, as I said before. The basic history of the comorbidities, trauma, intoxication, medical conditions. Was there asphyxia? Was there drowning? Was there some other aspect of the scene that might have contributed to the condition they're in right now? Do they have medical conditions that you know of? Asphyxia, yes or no? These numbers that we showed with the ECMO was not for asphyxia, and the whole resuscitation of avalanche patients is a completely different topic. And this Swiss staging system is really not to be used on patients that have suffered significant asphyxia. It's really for just primary patients getting cold with nothing else happening. So if patients were asphyxiated either through drowning or through burial in snow, their prognosis is much, much poorer. And then what did you do? What did you do once you got there? How long did it take you to get them out of that cold environment? Did you start an IV? Did you do vital signs? Obviously, you want to hand those off. Did you do any medications? Did you do any attempts at external rewarming? Did you put a splint on, et cetera, et cetera? So all that stuff, you should write that down if you can't keep it in your mind, but that needs to be relayed to the next person in the chain, whether that be the ambulance or the helicopter, whoever's going to be taking that patient to their final destination. And that's all I've got for now. I think this is a picture from a terrible European accident where 14 people were caught out in bitter cold conditions. And this is actually a photograph from that scene. And 14 of them stayed out overnight in -5 degrees C and 60-mile-an-hour winds, and 7 succumbed to hypothermia and 7 survived.
Yeah, and remember that hypothermia happens when there is an unexpected event, right? That surprise everybody off guard. This, this group of skiers, the marathon in China recently with 21 people dying from
Couldn't see
hypothermia.
where they were going, lost the trail.
Or someone that is, too drunk to, go back to their, tent and, stumbled back onto a ditch and they stay there for the rest of the night. That's when hypothermia sets up, when there is an unexpected event that caught that victim off guard. Great. With that, thank you. Thanks for the invitation. I have a small announcement to do. We're gonna circulate at some point, if we can, a rock and snow symposium that we are hosting at the University of Colorado on November 4th, in person, hopefully, or virtual. So if you guys want to know more, we'll try to circulate that link for registration.
Yeah, we'll get that on the MRA's email. And at this point, we're happy to take some questions.
Excellent. Well, Martin, Allison, that was very educational. And I got the first questions here. First question is from Doug McCall, and it's: when checking for a pulse of a suspected hypothermic patient, if we do not detect a palpable pulse within 60 seconds, then begin CPR, is there still a chance of putting the patient into cardiac arrest or other non-sinus rhythm?
You can take that one.
Yeah, there is a risk. I mean, that's why it's important to, maybe have a couple of people checking. Don't rush it. Again, use a central.
Warm your own fingers up.
Yeah, you might be cold too, so you might not have the same, tactile sensation on your fingers to detect. Sometimes, if in other environments where mountain rescue happens, if you have access to a monitor because the medics filled in, if there is any, we use Dopplers and other, technology. Ultrasound, if there is any available nowadays, there is a possibility to bring ultrasound in the phones, basically. But for the basic is have a couple of people checking for central pulses. Take it for a minute, and if you're not sure, take it for a minute and a half. And yes, if you don't find a pulse, start CPR, because that patient might have a rhythm, but it's so slow that it's probably inadequate perfusion rhythm, and that patient needs some degree of support.
Excellent. Next question. So there is a mountain rescue team out there that uses degradation of physical abilities as the primary indication of mild hypothermia, and reduced IOR as an indication of moderate. Can you comment why reduced physical abilities is not included in your evaluation or new scale? Is BICO rescue old school now? And I don't know what.
I'm not sure what all those abbreviations are talking about, but basically you're describing the umbles as somebody's decreased physical, what was the term? Abilities, it's just more difficult to reproduce those. And, they're so open to interpretations. What might be decreased physical ability and one might be normal, in somebody else. And so we tried to make it simple and reproducible, as Martine talked about earlier. And there's no research. How do you exactly quantify decreased physical abilities? It's just like unconsciousness versus, kind of unconscious or altered consciousness. You really need to have sort of definitions that everybody can agree on to use a staging system that everybody can use.
The staging system doesn't, take out all the other clinical symptoms and signs of hypothermia. Of course, if you are, if you have a normal level of consciousness, but cannot, perform simple tasks like, putting your boot in or, putting your gloves on, that patient is in mild hypothermia. But basically it's very variable, let's put it that way. And it's very difficult to put in a classification that needs to be used by a large number of people. But that doesn't mean that those signs are not important, right?
Excellent. So the next question I have is, we've all faced that situation where we have sometimes even a team member that's hypothermic, and you pull off their clothes, get them dried out, and you want to start rewarming. And one of the best ways to do that is to have that patient stand and walk. And at what stage is that contraindicated because you're potentially going to, put them in a cardiac arrest?
It's highly unlikely that anybody that is at risk, a high risk of cardiac arrest, is going to be able to stand and walk. So the patients that you're going to try to actively rewarm in the field are going to be in that stage 1 or stage 2. By the time they're at risk of cardiac arrest, they're really beyond the getting up and walking.
There might be a situation where patients are confused, maybe it has like a stage 2 moderate risk of cardiac arrest. And they have been a couple of situations where they try to walk that patient, there's a bit of, cold blood in lower extremities, and that return really decreased their core temperature and put that patient on cardiac arrest. I would say that if a patient is, confused to the level that they cannot walk, they shouldn't be walking, right? And if a patient is, a little bit in a better position, then it's matter of trying to prevent heat loss and to, move them out of the environment. And if the fastest way to do that is to move them into a vehicle or to something, you need to, move them and let them walk.
Again, that idea of you don't have to hurry, if somebody's super sick, there's no urgency in getting them up and starting to walk them. You get them dry, you prevent further heat loss, and you package them up. There might be other ways to warm them up. There are a couple cases, and again, these are mostly in the avalanche literature where people have been unburied and then, sort of make one final movement and then drop dead. There's that sort of rescue after drop that Martine was talking about, where the idea of the cold acidic blood is now circulating into the core circulation and causes cardiac arrest that way. But these are generally in, very ill patients, and not your kind of partner that you've just sort of seen get slowly colder and colder, who you're now trying to actively rewarm by drying them off, feeding them, and making them move.
Excellent. A lot of teams just recently have started to utilize the new military grade HPMKs, which are disposable rewarming kits. Do you guys have any experience with those and your thoughts?
Well, we use kind of a system similar. We use, in our team, we use a heating blanket. We use, a mid layer or insulation layer, and then we put a, if there is wet conditions, we'll put a tarp on it. So, thinking about the different layers of that, whatever you use, if you're using a specific type of chemical heat blanket versus another, we find that the basic layers of a good hypothermia wrap are reproducible with different type of materials, right?
Mm-hmm. Very good. Any other questions out there before we wrap up tonight?
Michael, what was the I guess Martin, what was the date of the, or Martine, what was the date of the snow and rock?
Rock and Snow Symposium in November 4th
November 4th.
in Aurora, Colorado, or through Zoom, depends.
Okay, awesome. That aligns very well with the IDERS symposium as well.
It's one day before the IDERS.
Perfect.
Martine and Allison, we'd just like to thank you very much for doing the August 3rd Thursday. We really appreciate it. And we look forward to seeing you guys at IDERS or some other great forum.
Thank you so much.
Thank you, guys.
Good night, everybody.